So topic for today is acute pulmonary edema. We'll be talking about it. Uh, Acute pulmonary edema has, we will be talking in following steps: definition, epidemiology, etiology and pathophysiology, staging, clinical picture, complications, diagnosis and management. So let's get started. Now, pulmonary edema is simply edema, pulmonary edema. So, what is extravasation of fluid from pulmonary vasculature to interstitium and to alveoli? So, you can see this diagram where your fluid goes from uh, uh, interstitium to the alveoli, to the interstitium and the alveoli. Okay. Okay. So, what is the physiology? Pulmonary edema occurs in 1 to 2% of the general population. Males are affected more than females, and generally in 40 plus age group because they are at high rate, cardiac risk. Okay, so etiopathogenesis. So, firstly, let us look at the normal. You must have heard about the starring principle. So, what is starring principle? Simple. You have the fluid here, fluid blood here, and that can move out through what? Due to increased hydrostatic pressure or due to decreased amount of protein and lymphatic or increased lymphatic negative pressure here. So here it can extravasate depending upon increased pressure in the pipes, decreased retention of the pipe due to decreased protein load, osmotic pressure, and if there is negative pressure by lymphatics. So this is the schematic. One second. Uh, so that is what it says in the diagram. So all these factors are important, and we'll discuss how they matter in a while. Obviously, lymphatics have also in load. Lymphatics can help in drainage. Okay, but what happens is when you have increased pulmonary artery capillary pressure that is greater than 18 millimeter of mercury, you can have the lymphatics fail. So it's an acute pulmonary edema. Compared it to chronic condition, say it is the pressure rises very slowly, then the lymphatic drainage can go up to 200 fold. So this is very important. The acuteness of the event is also important in pulmonary edema. If it will be chronic, then it will be low. Okay. Then pulmonary edema is defined, is classified into cardiogenic and non-cardiogenic. Non-cardiogenic pulmonary edema is frequently called ARDS. So cardiogenic pulmonary edema due to increased pulmonary capillary pressure. We saw the diagram, right? Where the vessel will have increased pressure. Why will the vessel have increased pressure? Either pulmonary capillaries, why will it have increased pressure? Probably because there is a back end, there is higher pressure. Why will the back end have higher pressure? Because either the left ventricle is failing or the left atria is failing. Because left ventricle was supposed to come to the heart forward. So what is happening here? Left ventricular has failed. Why is it failing? Either the left ventricle is intrinsically weak or there is increased hypertension. BP has risen up so much in the aorta that it is drawing the blood from aorta to left ventricle. Right? So one condition is very high BP, other condition is left ventricle is failing. You have a heart attack or anyway left ventricle has become weak. Other condition might be left atria pressure is only increased, where it can be, say in mitral stenosis. What is happening? Left atria cannot transmit blood to the left ventricle because mitral wall is blocked. So all of these will lead to a backward flow to the lungs. And the pulmonary artery pressure will rise up greater than 18 millimeter of mercury. So which are the cardiac disorders? As I told, that either you have a left ventricle systolic dysfunction, you have hypertension, Now you have left atrial outflow obstruction like myxoma, mitral stenosis, thrombosis of the wall. Okay. Then LV diastolic dysfunction, heart is failing to contract, right? Relax, so ischemia, that can be, and chronic LV failure. So pulmonary edema is less likely to develop in chronic LV failure because, as I told you, it is the acuteness of the event matters. So if it is chronic, but when acute event like ischemia or arrhythmia goes over the usual cardiac failure, then obviously it can again manifest as cardiogenic pulmonary edema. Causes of acute exacerbation of cardiopulmonary edema, as I told, right? Anything which hampers the contractility of the heart. So you will have heart attack, myocardial infarction. Patient is already, heart is weak. He has heart failure. So what do we advise in heart failure? Take less of salt and water. So he has started taking a lot of salt. So water is retained inside the blood, right? Increased osmotic pressure, we would call it. Then he is not taking medicines. So heart failure, since the pumping power is less, we advise to drain the water through diuretics. So he's not taking diuretics. Severe anemia, his HB has become very low. So osmotic pressure has decreased. So all fluid goes out. Then sepsis, thyrotoxicosis, myocarditis, myocardial toxins, and chronic valvular disease. So these are also causes. So this is a good schematic from NEGM where we can see what is the difference between cardiogenic and non-cardiogenic. You can clearly see that the cardiogenic have increased hydrostatic pressure, and that is leading to increased filtration, right? And and finally the alveoli is being flooded. Important, since proteins will remain here, and it will be protein poor edema fluid, okay, because the only fluid is going compared from non-cardiogenic pulmonary edema. What is happening here? Here the capillaries are getting damaged. Here the pressure is normal. So capillaries have become highly permeable, either due to inflammation or various things. And so even proteins are being transferred, so it's a protein-rich fluid. Okay. So generally the classification in generally in ARDS, which is a common form of non-cardiogenic pulmonary edema, the first condition is that your pulmonary artery wedge pressure, capillary wedge pressure (PCWP) should be less than 18. So that is what it says. That is your hydrostatic pressure should be not be raised. So this is a classifying criteria for ARDS. So in ARDS you will have normal hydrostatic pressure. This is very important. So clinical features of cardiogenic pulmonary edema. Obviously it will start at exertional dyspnea and orthopnea. Chest X-ray, you will have increased vascular markings in upper lung zone and curly V lines. So why increased vascular markings in upper lung zone? Generally what happens? Your vascular markings are a bit prominent in lower zones, right? Why? Because obviously due to gravity, right? The all vessels will drain towards the bottom side. But what happens is pressure is generalized, pressure is increased throughout. So what will happen? Even the upper lung zones, the vascular vessels will start becoming prominent, and as it will worsen, the vessels, the fluid from initially from blood capillaries, they will go on to vessels, capillaries, and then even the alveoli will fill in a perihilar distribution, and then it will go on to have diffuse alveolar infiltrates. So you see what is happening. These are the curly V lines at the periphery. So what you can see here, these lines were supposed to be prominent. So this is what is happening. We see in this case, even the upper lines, this thing has become prominent. Number one. And then you have perihilar infiltrates. This is hilum, and these are perihilar infiltrates. Okay. And if it goes on to develop further, then you will see these patchy infiltrates all around this thing, diffuse alveolar infiltrates. So initially start with curly V lines, then you have upper prominent here, then you have perihilar infiltrate, and gradually entire patchy distribution. In this thing, you can also note that there the heart is slightly enlarged. So this might be a cardiogenic pulmonary edema. If the heart size will be normal, possibly non-cardiogenic pulmonary edema. I'll discuss it later as well. So non-cardiogenic pulmonary edema, as I discussed, it was caused by changes in permeability of pulmonary capillary membrane, either via direct or indirect pathological insult. So direct insult, how can it be done? Chest trauma, aspiration, smoke inhalation, pneumonia, oxygen toxicity, pulmonary embolism. Nowadays, COVID is also important, viral pneumonia, which is very frequently causing ARDS. So these are direct injury to the other is indirect. For example, if you have sepsis, pancreatitis, so antigen antibody is going and damaging the pulmonary capillary pressure. Other cause, possible lung injury. There is a lot of negative pressure. So high altitude pulmonary edema, neurogenic and re-expansion. So there is increased negative pressure, and it is so. What is the possible cause? So as we said, that hydrostatic pressure, cardiogenic pulmonary edema. Other thing is pulmonary capillaries are damaged by direct or indirect mechanism. Then possibly negative pressure, high altitude pulmonary edema, neurogenic and re-expansion. So neurogenic pulmonary edema is an intrapulmonary salt, and they are rare type neurogenic re-expansion. So I will not discuss them further. ARDS, the pulmonary edema, as I said, it is initially pulmonary capillaries become highly permeable, then lead to influx of fluid into alveoli, and later on diffuse alveolar damage. Here the fluid will be protein rich as compared to, as I discussed, the hydrostatic cardiogenic pulmonary edema, where it will be protein poor. We see again the diagram. Here what you are seeing is, again you have perihilar infiltrates, diffuse, it is increasing. Here the heart size is normal. So this is most likely an ARDS type of picture. You will commonly see this even in the COVID patients. Okay, diffuse infiltrate in the ARDS stage. Then as I said, there can be high altitude pulmonary edema. Okay, so again, low oxygen, in response to low oxygen levels, vessels in lung will constrict and it will increase the blood pressure in lungs, which will cause fluid to leak from vessels. So this is a cause of high altitude edema. The solution is just oxygen. Okay, so vasoconstriction is impaired in this case. So you just give oxygen and it is solved. So re-expansion pulmonary edema, if you say if you do a thoracocentesis in pleural effusion, or if you put a chest tube in pneumothorax, then what will happen? The collapsed lung is expanding, fast. So what will happen is, due to negative pressure, the pulmonary edema can develop. So what is advised? You don't directly tap a lot. If you are doing a pleural fluid, removing pleural fluid, you generally don't withdraw greater than 1.2 liters. So do it slowly so that allow body to compensate and lymphatics to compensate. So this is another example. Complication: cardiogenic pulmonary edema, respiratory fatigue, ventilator, and patient might require ventilator also. So mainly, again, coming to cardiogenic versus non-cardiogenic, how do you differentiate? Some are clinical signs. Obviously, you will see an S3 gallop. JVP will be raised in cardiogenic, not so much raised in non-cardiogenic. Peripheral edema in cardiogenic. Okay. Then in non-cardiogenic, your pulmonary findings, fever, cough, it will be there prominent. Okay. You can look at X-ray, find larger heart size in cardiogenic pulmonary edema, or you can do an echo and see a decreased ejection fraction in cardiogenic pulmonary edema. On X-ray, as I said, you can see cardiomegaly in cardiogenic cause, non-cardiogenic cause heart size in normal. Curly B lines are periphery of lungs, and here it is uniform. Cephalization, because the pressure is raised, so even the vessels, even in the upper zone of X-ray, will be prominent. Here it will not be prominent. Then you will have pleural effusion because pressures are high. Then you have perihilar, right, around the hilar. Here, these factors due to pressure will not be there. So how do we approach the patient? We just take a cardiac history. We take up anything that is a history of pulmonary history, that is fever, cough. If the patient has aspirated, walks in high altitude. So these things. Right. We'll do a CBC X-ray and arterial blood gas. We generally don't do a pulmonary artery cath to measure a pulmonary wedge pressure. We will just do an echo. If echo has less ejection fraction, then most likely this pulmonary edema is cardiogenic. So what is the treatment? If the pulmonary edema is cardiogenic, this is how we treat: LMNOP, Lasix, morphine, nitrate, oxygen, and we take with the place the patient in an upright or with a head end elevated. Okay, so we give IV diuretics to decrease the vascular hydrostatic load. We start nitrate to vasodilate, and in morphine, mainly you will see Lasix and nitrate commonly being used, and oxygen. Other way is to give a positive pressure ventilation so that it will push out the fluid from lungs back to the normal blood vessels. Okay, so as I said, that acute cardiogenic pulmonary edema will have some factor which aggravated the heart failure. So that patient was breathing, heart was beating normally, then you had arrhythmia. So heart started beating abnormally and it failed. Or you have ischemia, heart attack. Okay. Or you other cause of decompensation. For example, patient has a blood loss. He started taking a lot of salt, a lot of water. So that is the cause, and it will be in cardiogenic pulmonary edema. If you give Lasix, diuretic nitrate, it will improve soon. Non-cardiogenic ARDS, this is very difficult to treat because here the pulmonary capillaries have been damaged. You don't have to collect pressure, you have to repair the capillaries. So that is why ARDS might require mechanical ventilation because it takes long. As I said, oxygen, you have to give oxygen either through oxygen cannula or high flow nasal cannulas. Okay. Then you can, as I said, you can also use positive pressure ventilation. Okay. So you can push the fluids back to the lungs, so from back to the blood vessels. And if the BiPAP or CPAP, non-invasive ventilation, doesn't work, you have to give invasive ventilation by intubating and delivering breaths. And then I already discussed decrease preload. We can decrease the pressure by diuretics, nitrates, morphine is rarely used, but it was very common. Other things what you can do is make the patient sit in upright position. Tell him to keep his legs dangling on side of bed. Okay, so all the fluid will go to legs. Okay, 0.5 ml, 0.5 liter, up to 0.5 liters. So these are methods which work very well in pulmonary edema, which is caused by pressure difference, that is the cardiogenic one. But this will not work much in ARDS, where actually the pulmonary capillaries have been damaged. So you would not get much by decreasing the by changing pressures. Here you will have to repair capillaries and to treat the disease pathology. Then inotropic drugs might be used if the heart failure is weak, but this is re-expansion pulmonary edema, as I already told, that you have to tap less than 1 liter, 1.2 liter. High altitude pulmonary edema, it is caused due to vasoconstriction. So I already told you, when you go up, you will have to do conditioning. So as the people who go on mountains, they do a conditioning. They go slowly, descend slowly. And the thing is, they carry oxygen with them to avoid pulmonary vasoconstriction, and they also take sometimes calcium channel blocker so that to provide vasodilatation. Prognosis, as I told, that cardiogenic pulmonary edema is relatively easy to treat with Lasix, morphine, nitrates, or with positive pressure ventilation, but you have to take care of the cardiac events. ARDS will respond slowly. Thank you.